Djamel Bensmail from Garches, you have the floor for talking about intrathecal baclofen.
So I know that your attention capacity now is very low, so I'm going to show you only some video for this talk. So I have to speak about the place of intrathecal baclofen in the therapeutic arsenal of neuro-orthopedy. First of all, I would like to focus on the mechanism of action of baclofen. It's a GABA B receptor agonist with an action on 1A afferences, endings, and polysynaptic reflex pathways, and without any action on corticospinal pathways at dosage used in the therapeutic purpose for spasticity treatment. And it's a very important thing. In a study that we performed some years ago, non-published data, we have seen that after a 60 micrograms injection of intrathecal baclofen, we have a huge decrease of H reflex without any modification of motor evoked potential in the tibialis anterior muscle, showing that baclofen acts on afferences and not on alpha motor neurons or on corticospinal tracts at the doses used for therapeutic purpose. What about one main question is the effect of ITB and dystonia? The mode of action of the drug explains the absence of action on dystonia, which is a dysfunction of basal ganglia with an excitability of corticospinal pathways and stimulation of alpha motor neurons. So the mode of action of baclofen explains that ITB is not efficient in the cases of dystonia. So if spasticity prevails, we have a high efficiency of this treatment. If dystonia, chorea, or balism prevails, we do not observe any efficiency or just a little efficiency, because there is always some a part of spasticity in the disabling situation. In any case, trials allow to distinguish the various components between orthopedic, dystonia, and spasticity in this patient. And it explains little or no satisfactory effect of ITB in some anoxic patients, TBI patients, or CP patients with predominance of dystonia and not spasticity. At the same time, we have, of course, to look for and treat irritative factors, but we don't have to wait for irritative factors treatment before treating spasticity, because in some cases, after 3 months, it's enough to observe a degradation of the orthopedic condition of the patient. You can see this kind of patient. If we treat early this kind of patient, it's possible to prevent orthopedic complication. If you wait for pressure source healing, for example, it's too late, and we will get a lot of orthopedic complication. Intrathecal trial is very easy. We don't need a lot of things. It's performed at the bed of our patients, and it's a very easy technique without any difficulty in a PMR department, and it's very easy to perform. We can see this lady before trial. And the question is, was this the different component? We have the very severe spasms of, particularly in the left limb, without any possibility to extend the knee, with a very huge cerebellar syndrome in this case, in a MS patient. It's difficult to before the trial to know what is the part of the disabling situation due to spasticity and the orthopedic components of this disabling situation. When you see the patients 3 hours after the trial, you can see that finally the orthopedic contractures and are not at the first in the foreground, and it's the spasticity that is more disabling in this kind of patient. She is more comfortable. She's able now to sit down in a wheelchair. She's not painful, and it's possible to prevent the aggravation of these contractures, particularly for hamstrings and hip flexor muscle. So isolated treatment of spasticity is enough in this case to treat the patient, because the goal is to improve nursing, to prevent contractures, to aggravation of contractures, and to facilitate sitting and laying in the bed in the right condition. Another clinical case of a 38-year-old man with an MS diagnosed in 15 years ago, with a third surgery 3 months ago for ischiatic pressure sore with a hamstring muscle flap. Few weeks after the surgery, the other team observed a dissension in the scar with a recurrence of the pressure sore, and he was referred to our team for spasticity management. It was impossible to sit in a wheelchair for a long duration, to perform transfer, to perform self-catheterization of the bladder, to dress or to wash himself. You can see him before the trial and before the management. It's impossible to extend. It's impossible for him to sit down in a wheelchair, to perform self-catheterization. You can see a very huge spasticity and spasm. At this time, we had the feeling that we will need our colleagues from orthopedy for an additional treatment of contractures after the pump implantation. We can see the patient 10 days after pump implantation, and the situation improved a lot. Of course, he's got contractures and retraction of the hamstrings, hip flexor, but now the situation is compatible with sitting in a wheelchair. He's able to perform self-catheterization of the bladder. It's possible to dress and to wash himself alone. And we see the patient 1 year after pump implantation without any additional orthopedic surgery, after pressure source surgery and rehabilitation. Now his knee are totally extended, and he doesn't need any additional surgery. He's totally independent in his activity of daily living. When we saw the patient for the first time, we were convinced that we will need orthopedic surgery, but finally it wasn't necessary for this patient. The goal is to avoid this situation. It's a lady with the MS that I see 2 weeks ago. It's amazing and incredible to see this kind of patients in 2017 in Paris area. But look at the situation. It was difficult to find her knee, but the knee was in front of the mouth. It's really incredible to see this situation. We need a bed in our department to take care of this patient, but as you can see, we see even in 2017 this kind of situation. So we don't know how we are going to manage this patient, but we would like to avoid this situation, because which lead to this kind of invasive treatment that Philippe performed frequently during the 90s. And fortunately, we don't have a lot of patients now treated with this kind of surgery with a very invasive treatment. As a conclusion, we can say that ITB trial can be used as an evaluation tool. It may allow differentiation between orthopedic impairment, spasticity, and dystonia. And it's very difficult sometimes, because with general anesthesia, it's not possible to differentiate spasticity and dystonia. With ITB, it's possible to differentiate spasticity and dystonia. ITB has an unquestionable place in the neuro-orthopedic therapeutic arsenal to prevent neuro-orthopedic complication, or associated to neuro-orthopedic surgery to avoid recurrence of contractures. The questions that remains is the sequence of the treatment, and each team has a different probably approach before neuro-orthopedic surgery, sometimes after neuro-orthopedic surgery for some patients, and when is associated neuro-orthopedic surgery necessary? Not always, but it's a question. The key point is the patient multidisciplinary assessment. We have to evaluate the benefit-risk ratio for each patient. These patients have not only neuro-orthopedic impairment, but also spasticity, neurogenic bladder, pressure sore, swallowing impairment, and so on. So it's a complex situation sometimes. Which treatment sequence to have? Should we start with neurogenic bladder management and then neuro-orthopedic management and spasticity management? We have still some question and debate in this field. The main limit of ITB, of course, is dystonia. And in some severe traumatic brain injury and anoxic patients or genetic dystonia, it's very difficult to manage them because after neuro-orthopedic surgery, there is very often recurrence of the orthopedic condition and of the contractures. Many thanks for your attention.